Thank you, folks, and welcome to the Sight and Sound Bites webinar series brought to you by the Eye and Ear Foundation. This biweekly webinar series highlights research at the University of Pittsburgh School of Medicine. Today's topic is cataracts, the latest developments in treatment. So I am Lawton Snyder, CEO of the Eye and Ear Foundation. The Eye and Ear Foundation supports research to advance care for vision, balance, voice, and cancers of the head and neck at the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds we provide from the Eye and Ear Foundation support research are only made possible because of philanthropic support. So our support supports the research that you're going to see has contributed to a lot of the advances that you hear about through Sight and Sound Bites. Thank you for those who have made those contributions. A little housekeeping. So this is a Zoom product. You recognize that it's just like you do a Zoom with your family, but this is a webinar series. We disable the chat, so you won't be able to chat your friends, but you will be able to ask questions, and you can do that anytime during the program by using the little bubble down at the bottom. It says Q&A. I already see we have a question, as a matter of fact. You can do that anytime during the program. And then what we'll do is I'll read those questions to our panelists at the end of the program. We will ask for you to refrain from asking questions that would be very personal to you that may not be as interesting to the rest of the group. I may pass those over, but certainly you're welcome to ask us any questions. You can always email Craig Smith, or we'll get to those questions that you may have and make sure we answer those. We will send out a survey that you'll receive in the next day or so, and we ask that you would look at that and complete that. We've used those surveys to continue to make improvements to our program, and then we'll add everybody to our email list to receive future webinars, which I think again it will continue to be doing, into the future. So here to introduce today's program and today's speaker is Dr. Deepinder Dhaliwal. Dr. Dhaliwal is a professor of ophthalmology at the University of Pittsburgh School of Medicine. She's the director of refractive surgery and the director of cornea services at the University of Pittsburgh Medical Center Eye Center. Dr. Dhaliwal also serves as the director of UPMC Laser Vision Center, the associate medical director of the Campbell Ophthalmic Microbiology Laboratory, and has recently been appointed as the director of the Cornea Stem Cell Task Force at the University of Pittsburgh. For good reasons, Dr. Dhaliwal has lots of titles and lots of responsibilities because she's someone who is one of our favorite people to have here in our webinar series, and she's a lot of people's favorite doctor as well. Dr. Dhaliwal, welcome and thank you.
Thank you so much, Lonnie, for that very, very kind introduction. And a big hello to all of you out there in Zoom world. We are thrilled that you're joining us today. And really thank you. It's such a gorgeous day outside. We are really thankful that you're going to take this next hour to learn more about cataracts and cataract surgery. And to dive deep into this topic, I would like to introduce my wonderful colleague, Rohina Kamyar. Rohina sees patients more in the St. Margaret office, in the St. Margaret location, and she is a clinical assistant professor at the University of Pittsburgh. She started in California and did her undergraduate degree there at the University of California in San Diego, then did a master's program at Stanford, and then moved to Michigan, where she did medical school, her residency, and a fellowship in cornea and external disease. We were so lucky because Rohina moved to Pittsburgh in 2010 and joined us in the Department of Ophthalmology. And we have just been so excited to have her as a colleague and learn from her and, just share cases. She's absolutely lovely. She also has a very important role as the Associate Medical Director of the eye bank, of the core eye bank, which is really, really an important function as she reviews corneal donations and corneal transplant tissue. So I would like to now introduce Rohina Kamyar, and she's going to talk about a topic that is, again, near and dear to all of our hearts, cataracts, the latest developments in treatment. So Rohina, please take it away.
Thank you so much for the kind introduction. And I thank you for the opportunity to present this talk. So we're going to talk about cataracts, and I kind of want to answer some very common questions that I get when I see my patients in the office. So what is a cataract? A cataract is a clouding of the eye's natural lens. You can see here in this picture of a normal eye, the lens focuses light that's shined into the eye onto the retina and allows you to see a clear image. And in an eye that has a cataract, this clouding of the lens causes the light to scatter, and so you don't get that nice crisp image on the retina anymore. The lens grows thicker over time. This is a normal age-related process. It's kind of goes along with gray hair and wrinkles. If you are lucky to live a long life, you will get a cataract. It's very normal to have one. Eventually, over time, this lens in the eye becomes cloudy, and that's when it starts to affect your vision. So again, this is a normal age-related process. It usually grows very slowly. And most people over the age of 55 will have some signs of cataract. So what causes a cataract? So I just want to describe this picture here. So you can see this eye has a very cloudy cataract. This is a bit more advanced of a cataract. You can see the iris here, the pupils dilated, and this cloudiness here is the cataract. Aging is the most common cause, but we also see cataracts associated with diabetes, smoking, if you had any previous eye surgery like a retinal detachment repair or any injuries to the eye. Spending a lot of time in the sun is actually associated with cataracts. And certain medications can speed up the progression of your cataracts, namely corticosteroids, so like prednisone. The symptoms of cataracts are, the most common complaint we'll hear is blurry vision. Also, we'll hear people describe faded colors not looking quite as bright or as clear. And I think this is a beautiful illustration of what cataracts can do. This first painting here is by Claude Monet in 1899, before he was diagnosed with cataracts. And the second painting was done 20 years later, when he had a diagnosis of cataracts for at least 10 years. And you can see the colors are much more murky. Everything's yellowish and orange tinted. Apparently in his later life, he had to have the paint tubes labeled with the names of colors because he was having difficulty differentiating them. Another common complaint we'll hear about is halos around lights. So especially when driving at night, car headlights can have halos and make it difficult to drive. And again, trouble seeing at night. People will say that they need more light to see. They need extra light to be able to read at night because things look dimmer. How can I slow down the progression of cataracts? The one big thing is wearing sunglasses with UV protection. So since we know that UV light can speed up the progression of cataracts, wearing sunglasses can be really helpful. If you smoke, we'd encourage you to stop smoking. And if you have diabetes, make sure to keep your blood glucose levels under good control. And is there an eye drop that will dissolve my cataract? Unfortunately, the short answer is no. There's been multiple studies that have looked at different eye drops, and we really haven't found anything that can get rid of a cataract. So the gold standard of treatment is cataract surgery when your cataracts are ready. So how do we diagnose cataracts? The first thing that we'll do is a comprehensive eye exam. So this means doing a full exam with checking your eye pressure, dilating the eyes. There's other things that can cause the vision to be blurry besides cataracts. So we want to make sure there's no glaucoma, there's no macular degeneration, or anything else that can affect the eyes. Dry eye is actually a very big reason that you can get blurry vision. That usually causes more of an intermittent blurry vision, so it kind of comes and goes, versus a cataract gives you a more constant blur of your vision. The other thing that's important to do is have a good refraction, so to have your optometrist make sure your contact lenses or your glasses are as up to date as possible. In the early stages of a cataract, actually just changing the glasses prescription is all you really need to bring your vision back to a good level. And once the cataracts have progressed more, even glasses or contact lenses won't really help clear the vision. And that's when we know that the cataracts are more ready for surgery. So when should you consider cataract surgery? If your cataract symptoms are not bothering you too much, it's not necessary to have cataract surgery. So sometimes we'll get people that are worried that they've been diagnosed with a cataract, that they have to do something about it immediately. And that's really not true. It's normal to have a cataract. It's just a matter if it's affecting your vision, then it's something to consider. And when it becomes difficult to do the normal activities you do day to day, or if you feel unsafe driving, that's when we really want to consider cataract surgery. So how do we do cataract surgery? First of all, this is an outpatient surgery. We give you light IV sedation, so we don't put you fully out. It's really not necessary. This is a very short procedure. We make a 2 millimeter incision, tiny incision in the cornea. And through that incision, we create an opening in the lens capsule that contains the cataract. So this is, you can see here, this is the lens capsule opened with the surgery. We call that a capsulotomy. I like to think of the cataract as an M&M. So you have a shell and then the chocolate in the middle is the cataract, and we want to actually leave that shell in place. So we create a small hole in that shell to get your cataract out, and then we leave that shell in there because that's where we're going to put your new lens implant. So once we have that capsulotomy, we're going to use an ultrasound probe to remove the cataract. And then again, we're going to put that lens implant in that shell or that lens capsule. A common question that we get is the cataract surgery done by laser? And so that's actually not how traditional cataract surgery is done. There in the last 10 years or so, there has been femtosecond laser assisted cataract surgery. This is a procedure that where the incision can sometimes be created by the laser. The opening in the lens capsule is created by the laser, and the cataract is softened by the laser. One thing that's really important to know is that cataract surgery, there's about 10 steps to the surgery. The laser only really does the first 3 steps of the cataract surgery. So the rest of the 7 steps of the surgery are done the same way, regardless of whether you have the laser used or not. Again, so the rest of the surgery is done the same way. So what are the benefits? What are the pros and cons of having manual cataract surgery or femtosecond laser cataract surgery? So the benefits of manual cataract surgery, it's actually faster than having the laser surgery. There can be less inflammation. There's no additional cost to you. So this is covered by insurance, and it's actually more comfortable for the patient because with the laser, we have to put a big device that applies a lot of pressure on the eye. The cons are that there are certain types of situations where the cataracts can be really dense or the cornea can be really cloudy, so it's hard to see in the eye, where maybe the laser would help a little bit, but that's a very rare situation where that would be the case. And the pros of laser cataract surgery, again, is just in those certain types of cataracts, it can be really helpful. The cons are there's an out-of-pocket expense, so insurance does not cover the laser. It's slower, and you can have more inflammation and swelling in the cornea after laser surgery. So multiple trials have been done comparing manual versus laser cataract surgery, and there really has been no significant difference found in outcomes. So both methods are as good in terms of vision, patient-reported health, and safety outcomes. A person's outcome really depends in large part on the skill and experience of your surgeon. Yeah. Dr. Dhaliwal, did you want to like comment on your experience with lasers? We both have trialed them in our practice. What do you think of them?
Sure. Thank you, Rohina. You know, I completely agree with you. I think that, you know, lasers, we use maybe 6 or 7 different types of lasers in ophthalmology in our practice. So this is a specific laser that can help with certain parts of cataract surgery. And, you know, we've trialed them. And I will say that probably 98% of the cataracts that I do, I find it easier to do just without a laser. There are probably 2% of cases, and I did have one where there was just no view in. The cornea was so cloudy, there was so much scar tissue that the patient really could not have, you know, traditional cataract surgery. And so we did use a laser, and that did help this particular patient. But in those are so few and far between. The great majority of cases, I completely agree with you. I actually feel better doing everything by hand because I feel like it's more predictable and I know what's going on. And actually with the laser, I actually had some issues. So, you know, again, it all depends. As you say, the bottom line is the skill and experience of your particular cataract surgeon. I think you said that beautifully.
Yeah, I agree. All right, so next I'm going to talk about different intraocular lens implants. So there's 4 general categories of different lens implants: monofocal, multifocal, extended depth of focus, and toric. So the first lens option, that's covered by insurance. The next 3 are not covered by insurance. So we'll go in detail for each category here. So monofocal lenses. This is the most common type of lens implant used during cataract surgery. This lens implant offers excellent optics. We think it can offer really excellent vision. It has a single focus that can be set either for distance, intermediate, or near. Most people choose to have good distance vision and wear their reading glasses for reading or for using the computer for their close work. One option that you can do with monofocal lenses is monovision. So monovision is where one eye is set for distance and the other eye is set for intermediate or near. This usually works well. However, some people can have trouble with their depth perception. If we thought that maybe you might have a little trouble with the depth perception, we sometimes will recommend doing a trial in contact lenses so you can kind of try it out before you have the implants done, where then it's more permanent. And you will still need glasses in this situation. So unfortunately, it does not eliminate the need for glasses. You'll still need them usually for nighttime, for night driving, sometimes for close reading. A lot of people will still need glasses for that. And so multifocal is another type of lens implant. So you'll see in this type of lens implant, they have these rings. This one's a little bit more faint, but it also has these different rings. And this is designed to provide both distance and near vision. And different zones are set at different powers to give you both the far and the near vision. Extended depth of focus is a different kind of lens that's very similar to the multifocal. So again, you see these rings on the lens implant. The main difference is that instead of multiple focal points, there's a single elongated focal point to enhance range of vision or depth of focus. So for both of these types of lenses, the benefits of this is hopefully to have less dependence on glasses after surgery. However, it's important to know 20%, they did a big analysis of multiple papers looking at thousands of patients that have had these lenses. They found that 20% still needed glasses for distance, and 30% of these patients still needed glasses for near. So these lenses, although they're trying to give you both distance and near vision, it's not a guarantee that you will be glasses free afterwards. So there's still a likelihood that you'll need glasses in certain situations. And the major con that we see with these lenses is night vision. So this is an example of glare that you can see after these lens implants. So this halo is supposed to be the type that you would see with multifocal lenses, and this is with extended depth of focus lenses. But you will have some degree of these halos. The question is, how much does it bother you? In certain people, it does affect their night vision to the degree that they do not feel safe driving at night. You can also have decreased contrast sensitivity. So trying to read something written in light gray type on a white background might be difficult to differentiate with these types of lenses. And dry eyes can degrade the quality of vision. So even mild dry eyes, if you feel like the dry eye, you have a little bit, but it's not bothering you too much, with these specialty lenses, it can really degrade the quality of the vision to the degree that you're not seeing things as sharply as you want to. And so it's really important, if you really want one of these lenses, it's important to optimize your dry eyes before surgery. So try to get the dry eyes under control beforehand. And most likely you will need to continue that treatment after your surgery. And other things can affect the quality of the vision with these lens implants. So if for some reason you develop glaucoma in the future or had a retinal detachment, that can affect the quality of vision that you'll have after you have one of these lenses. So really, in conclusion, you really need to have kind of a very healthy, eye if you really strongly want one of these lenses. Another general category of lens implants is a toric lens. And so what is astigmatism? So the toric lens is correct for astigmatism. This is a diagram of the shape of a normal cornea. It's round, kind of shaped like a basketball. And a cornea with astigmatism is elongated, more in the shape of a football. This is correctable with glasses or contact lenses. However, if you wanted that astigmatism correction in your lens implant, then you can choose a toric lens. You have to have a certain degree. So most people have a small degree of astigmatism, and for small degrees of astigmatism, we really don't think you need these specialty type lenses. But if you have a more moderate degree of astigmatism or more, this can be helpful. This comes in either a monofocal or a multifocal option. How do we determine the lens power? We use certain formulas. And one thing we just want to say as a disclaimer, this is not an exact science. So we take measurements of the length of the eye and the shape of the cornea. We use advanced formulas that estimate the power of the lens implant to be used for each eye. And these formulas are extremely accurate, but they're not 100% perfect. And there is a possibility of overcorrection or undercorrection, especially in eyes that are very nearsighted or farsighted. If you've had any previous refractive surgery, that can also affect the calculations. And important final points about lens implants. Your final outcome after cataract surgery depends on how you heal. So how the implant settles in your eye, it'll be different for different people. And no surgeon can guarantee what the final outcome will be after cataract surgery. And the choice of the lens implant is not the same for everybody. So the lens that was, chosen for your neighbor, your best friend, might not be the best option for you. Every person is so different. And we can never guarantee that you'll be glasses free after cataract surgery. And Dr. Daliwa, I just wanted to see if you had anything to add to that about lens choices or anything like that.
Thanks, Rohina. I think you did an absolutely masterful job explaining such a complex topic. And, we spend a lot of time in consultation with you as a patient. So when you come to see us, we have to do the full eye exam. We have to look at the data. We have to look at the corneal curvature and the status of the rest of your eye. So as you say, these new multifocal lenses, trifocal, extended depth of focus, these are really exciting options that we have. However, they don't work for everybody. And so what we want to do is find the best optical solution for you as an individual patient. And the most important thing that I could say is it is not one size fits all. Okay, we have to have an individual discussion with you, looking at your personality, looking at your hobbies, looking at your needs and wants. And the important thing is also, I would highly encourage you not to compare your choice of implant with your friends, because sometimes I find that my patients' friends make them a little crazy because, you know, you may have chosen a different implant, and then the friend asks you why you chose that, or, you know, why we did this, or, and, you know, it's honestly a discussion. What I empower my patients to say is that, you know, that they had a conversation with their cataract surgeon and they came up with a solution, and that's kind of the end of the story. And so it's not like, you know, shopping for the best this or that. It's such an individual thing, and everybody's eye is different. And sometimes we choose one implant for one eye and a totally different style for the other eye. You know, everybody's eyes are different. So again, this is a very individual choice. And we spend a lot of time in discussion to figure out what would be best. And so, you know, again, I would highly encourage you guys, all of you thinking about cataract surgery, implants, that, you know, have that discussion face to face with your surgeon and come up with the best solution for you as an individual. And don't compare notes.
That's great. Thank you. All right. So one other common question is, can I have dropless cataract surgery? What is dropless cataract surgery? So usually we'll use an antibiotic and steroid eye drop at the end of your surgery, and you're on those drops on a tapering schedule over 4 weeks. Another option is to inject that antibiotic and steroid into the eye at the end of surgery, and then you don't necessarily have to use the drops after surgery. So what are the benefits of that? Of course, you know, not needing to use eye drops after surgery would be wonderful. The cons, one issue is with the antibiotic. There's really not any FDA approved antibiotic agent that is available to be injected into the eye. And so those medications have to be made by a compounding pharmacy. And then there can be an issue with toxicity in those situations, or infection. And also, doing dropless cataract surgery doesn't necessarily guarantee that you won't have to use drops. So there is a subset of people that they have rebound inflammation where they'll still need to use steroid eye drops after surgery. So what I tell my patients, if they're able to do the eye drops themselves, or they have friends or family that can do the drops themselves, I usually prefer that. However, if someone really can't do the eye drops themselves and don't have anyone available to help them with the eye drops, then I think this is a great option for them. So that's something to really discuss with your surgeon if that's something you'd like to consider. So a very common question, what is the difference between Lasik and cataract surgery? So we'll have people ask, can I just get Lasik instead of the cataract surgery? So Lasik is a completely different procedure than cataract surgery. In this diagram, you see the cornea, which is the very front part of the eye, and then you have the lens, and then the retina. So Lasik is done on the cornea, and this basically reshapes the cornea to improve the prescription in the eye, whereas cataract surgery is done on the lens of the eye. The good thing about cataract surgery is that it actually, we can choose a lens implant to correct your vision. So kind of to try to do the same thing that Lasik would do in terms of reducing your need for glasses, but it's a completely different procedure. When you have a cataract, when the lens is cloudy, even if you had Lasik, it's not really going to improve your vision. Really, the next step in that situation is cataract surgery. What are the risks of cataract surgery? So there's a long list of risks. We don't expect any complications with cataract surgery, but it's important to be informed. Complications with cataract surgery happen less than 5% of the time, and some of the more serious ones like infection are extremely rare, 1 in 2,000 or 1 in 3,000. But it's important to know this before you decide to schedule your cataract surgery. Another common question, will my cataract come back? The answer is no, so your cataract's not going to come back. But there is this thing called posterior capsular opacification. This is also, some people will call it a secondary cataract or a secondary membrane. This can make it feel like your cataract is growing back. Your vision can become blurry. It usually develops really slowly. It can happen months or years after the cataract surgery. And here you can see this lens has become cloudy. This is actually quite common. Up to a third of people after cataract surgery will develop this at some point. The good news is that this is really easy to treat. We do a laser treatment in clinic. The laser takes about 10-15 minutes. The vision recovers within hours, and it's a one-time thing. So once you have it done, the lens stays clear, so you never really need to repeat this procedure after. And here you can see the difference. Almost immediately, the lens will look nice and clear after that laser procedure. So in summary, cataracts are a normal age-related condition. So everybody at some point in their lives will have a cataract. Cataract surgery is performed when your symptoms are affecting the quality of vision, and it is not correctable with glasses or contact lenses. And there are many different IOL options. The choice of the lens implant may be different for each individual. And there have been many advances in technology for cataract surgery, and there will continue to be. Talk to your doctor about whether any of these technologies will give you a better and safer outcome, because that's the most important goal with having cataract surgery. All right, and then we'll open it up to any questions.
Thank you, both Dr. Kamiar and Dr. Dhaliwal. Dr. Kamiar, maybe if you can stop sharing so we can see everybody. There we go. And this obviously we knew would be a popular topic. As we prefaced, this is a very common condition, and we have a lot of people on today, and we have a ton of questions, so we should jump right into the questions. So first question, what are the risks of having cataract surgery with things like bilateral nion, which again is an optic nerve condition, right? Could the patient lose additional eyesight, if they were to have a cataract surgery?
So in that kind of situation, we wouldn't expect there to be any additional loss of vision. It would be important to make sure your pressure is kept under control, because if the pressure became high and you had some glaucoma associated with that, that could cause the nerve to become further damaged. However, one thing that's important is if you already an optic neuropathy, the quality of vision might not be what you wish it to be after surgery. So there will be some limitation in the vision potential in that situation. But normally we wouldn't expect there to be any further worsening of the optic neuropathy with the cataract surgery.
Thank you. How fast did you say a cataract will develop?
So cataracts normally develop very slowly over years. And we start seeing the first signs of cataract around the age of 55. There are some fast types of fast growing types. And we usually see these associated with diabetes or with any prednisone use. Those normally will give like a faster type growing cataract, but normally the cataracts take years to develop.
Okay, and well, someone said thank you for the webinar. You're very welcome. We love to do these. Can these cataract procedures be performed on people with glaucoma or who are glaucoma suspects? Oh, there you go.
Yeah. So yes, these procedures definitely can be performed in people with glaucoma and glaucoma suspects. One thing that's really important is to make sure the eye pressures are well controlled before you do the cataract surgery. Another thing is that if you're already on a lot of eye drops for the glaucoma, there's a lot of great minimally invasive glaucoma surgeries that are now available, and sometimes that will be done in conjunction with your cataract surgery. So we usually have our glaucoma specialists do that combination type procedure. But the most important thing if you have glaucoma or your glaucoma suspect is just to make sure the pressures are well controlled beforehand, that your visual fields and your optic OCT is a type of measurement that we do of the optic nerves are not progressing before you would have your surgery.
Yeah, and I want to echo that, Rohina. Yeah, as Dr. Kamiar stated, cataract surgery is an opportunity to decrease the intraocular pressure even more with a combined glaucoma procedure. So there is one procedure that's only approved at the time of cataract surgery. So definitely, if you have glaucoma or you're a glaucoma suspect, see a glaucoma specialist so that they can combine these technologies, and maybe you'll be able to use less drops after the cataract and combined glaucoma surgery.
That sounds like really important advice. Thank you. So, is it ever necessary to replace the interocular lens again after a cataract surgery?
So that is extremely rare for the lens implant ever to have to be changed. These lens implants should last for your whole life. They have gone under rigorous developments, and the lens implants that we use these days are really great. They're made of synthetic materials like acrylic, and they should really last your whole life.
This is an interesting question. I agree. I often see coupons and deals online for eye surgery. This gives me huge cause for concern. Are patients aware that insurance is widely accepted for eye surgery?
Yes, no, that's a great question. I think that I would definitely be a little bit concerned about any coupons for eye surgery. Your eyes are so important. You really want to make sure that you have the best quality surgery. You really don't want to have a discount for anything. Dr. Dalibat, do you have anything?
Yeah. I think that perhaps these coupons and deals are for Lasik eye surgery. So people kind of say laser eye surgery, and it's so confusing now that some lasers are used in cataract surgery as well. But I believe the deals that I've seen are more for Lasik eye surgery. And I would echo what Dr. Kamiar just said. These are your eyes. You only have two for your entire life. So this is not the time you want to cut corners or go shopping around for a good deal, because it's super important that you have the highest quality surgery if you do choose to have laser vision correction. So LASIK is not covered by insurance. Any laser vision correction is something that's completely elective. It's something that we do for patients who do not have a cataract. So they basically just want to have more freedom from their spectacles or contact lenses. And that is, we do this often for our patients. There's a lot of interesting technologies. In fact, we need to have one of these sight and sound bites on refractive surgery in the future to talk about all the amazing procedures we have for that. But that is not covered by insurance. So there you go. But don't use a coupon. Come see us. We'll take care of you.
Would glaucoma affect the multifocal and EDOF differently than a person who had a multifocal IOL? Sorry for the abbreviations there.
Yes, yeah, so definitely we wouldn't expect the best quality vision with the multifocal or EDOF lens if you have glaucoma. And sometimes the glaucoma can cause certain parts of the visual field to not be quite as good as other parts. And if you can imagine those multifocal lenses with different zones, that can really cause a disruption in the quality of the vision. So if you have glaucoma, we definitely want to steer you away from those lenses to give you the best quality vision.
So what's the normal lifespan of the lenses?
I don't know if anyone's ever looked at that specifically, but it should last years. We put even these lens implants in young adults, and older children, and we expect these lenses really to last a lifetime.
Yeah, we put these in babies. These lenses will outlast us by
Wow.
hundreds of years, by centuries. It's a really wonderful biocompatible acrylic material that will last, I think, forever. I mean,
Yeah.
Wow, that's terrific. Are there IOLs with tints to use for people with poor color discrimination?
There is a yellow tinted lens. So that's the only tinted lens really available, but we don't necessarily use that lens for color discrimination. So actually, usually in that situation, I would think the clear lens, the clear tint would be the best option. Dr. Dhaliwal, what do you think about that?
sorry, I was dealing with a patient issue, but there's not, to my knowledge, something with poor color discrimination to actually improve that. What we would do is, I actually like using clear lenses, and we would have you see one of our optometrists who would help with glasses over top of the implant, so that you can optimize your color discrimination. There are some glasses that can help with that, but not implants, to my knowledge.
Thank you. These are very interesting questions. Thank you, audience here. How many diopter difference can there be between eyes?
That's a great question. I'm assuming we're kind of talking about monovision. Most people can tolerate up to 1.5 diopters of a difference between the two eyes. However, some people, especially if they're used to monovision, they've done it for years in contact lenses, or they naturally have monovision, they can tolerate a little bit more of a difference between the two eyes. In some people can't even tolerate 1.5 diopters of a difference. So everyone is different, but on average, what we've seen is that 1.5 diopters is kind of like the most that most people can tolerate.
Okay. So how long would a person need to be on the eye drops?
Usually about 4 weeks. So
Okay.
We have you on the antibiotic for just 1 week, and then we taper a steroid drop over 4 weeks.
Will cataract surgery increase tendency for macular degeneration?
No, so it does not increase your risk of developing macular degeneration. If you already have macular degeneration, if you have the dry form, that we found no association with any worsening after cataract surgery. If you have the wet form of macular degeneration, it's important to make sure that's under control before you have the cataract surgery. Sometimes you can get some swelling in the retina that can exacerbate the wet macular degeneration. So usually we have the retina doctors kind of seeing you in conjunction with us and helping to make sure that's under control before we would do the surgery.
Thank you. That sounds like great advice. How long is recovery?
So vision recovers usually fairly quickly within a couple days. However, we really say the eye is completely healed a month after surgery. So everyone's so different too in terms of how fast they heal. I would say on average, most people are seeing pretty well within a few days after their surgery.
If a person is on blood thinners, does that increase the complication of bleeding? Should the patient stop the blood thinners before surgery?
No, we actually do not stop blood thinners with cataract surgery. So where we're operating in the eye, we don't expect any significant bleeding. sometimes you can have a little hemorrhage on the white part of the eye. It's kind of like a tiny bruise on the white part of the eye, which does not affect your outcome or your vision at the end of surgery. We usually feel that the risk of bleeding is so low that it's more risky to actually stop the blood thinner than it is to stay on it.
Yeah, and I'd like to echo that point. I completely agree with Dr. Kamir. The one caveat, though, is that we do topical cataract surgery. So our technique is to not use a needle to numb up the eye. So that's why we don't want you to stop your blood thinners, because literature has shown that if you need to be on blood thinners and you stop them around cataract surgery, you actually have a higher risk of blood clotting and problems. So the technique, though, is topical cataract surgery, which we feel is very, very safe. And there's no needles going behind. Now, if your surgeon does not use topical cataract surgery for anesthetic or topical anesthesia for cataract surgery, topical just means we use drops and gel. We don't use injection. If your surgeon uses kind of more of an injection, then there is a risk of bleeding. So you need to have that conversation with your surgeon, depending on which technique they use, and really ask them what they feel is the safest. But absolutely, for our surgeries, we often, most often just use topical, especially if you're on blood thinners.
A lot of very good information here. Thank you so much. What's the probability of a need for a second surgery for an eye that has glaucoma?
So so I think probably we talked about in the complications that sometimes the pressure can be high. So that usually happens immediately after the surgery. So within the first 24 hours, this is very, very rare, but sometimes the pressure can be high. And that usually can be treated with eye drops. So usually it does not require a surgery for that. Now, if you already had glaucoma and you had cataract surgery and your glaucoma was worsening, it probably would have happened regardless of whether you had cataract surgery or not. And that might be something that would require glaucoma surgery in the future. I hope that made sense.
Thank you. So this is someone who's in vision rehabilitation asking this question, who works, I guess, in vision rehabilitation. Many of my clients say their vision is worse after cataract surgery. Can you explain this?
I'll take that one, Rohina. So that is a very interesting point. If you're in vision rehabilitation, it may mean that you're dealing with patients that have low vision to start with. And so when people say their vision's worse after cataract surgery, it might be because they are not focusing at the same point that they were used to focusing at prior to the cataract surgery. So remember, like Dr. Kamir mentioned, we remove your cloudy lens, which is the cataract, and then put a clear implant in its place. It's important to discuss which focal point we should target. So distance is common, or intermediate. I use a lot of kind of that intermediate target, which is kind of an arm's length or a computer screen length as a target, because I feel like that's really useful vision and kind of a lot of our life is at that focal point. But if a patient was very nearsighted preoperatively, and then they lose that amount of nearsightedness, they're going to feel like they see worse because they're not able to hold something close and read it anymore. So that's a nuanced thing. Other reasons why people can lose vision after cataract surgery: swelling in the cornea, swelling in the retina. God forbid if they had infection, they could lose a lot of vision after cataract surgery. But the most common things are, just kind of a change in the focal point that the patients weren't aware of, or swelling.
Thank you again. So if you had a retinal detachment after cataract surgery and later on needed a second cataract surgery, is there a risk for another retinal detachment?
That's extremely rare to happen. Usually when you've had retinal detachment repair, your retinal surgeon will do a lot of protective laser in the eye to hopefully prevent you from having another retinal detachment. But that is definitely something that we would monitor very closely for afterwards. A lot of times, the people that are most at risk for a retinal detachment have very elongated eyes, and the retina is quite thin. And sometimes those people are just unfortunately more susceptible to developing these retinal detachments.
Thank you. So is your vitreous, if your vitreous has already detached, how much risk, oh, there's no risk of retinal detachment. I think we just answered that, didn't we? Yeah.
No, actually, this is a different question. This is somebody who's definitely familiar with the eye. So they're asking if the vitreous has already come, basically separated from the retina. How much
Okay.
risk is there of retinal detachment? And that's a great question, because the risk is lower if your vitreous has already separated from the retina before cataract surgery. So remember, one of the reasons we don't do cataract surgery in young people who are nearsighted is because there's a very high rate of retinal detachment, mainly because the vitreous, we're changing the anatomy in the eye. So the lens, the cataract is, has this volume, and the implant has this volume. So it's a much thinner foot plate. And what happens is the vitreous comes forward, and then it can pull a piece of the retina off with it. So if your vitreous has already separated, the risk of retinal detachment is lower, but it's never zero.
Very good. Lots of good questions. We may not get to them all as we're running a little bit out of time, but what we try to do is, if we run out of time, we'll send those emails out to those people that have asked these questions. Does prior DMEK complicate cataract surgery?
Yeah, that's a great question. So if you've had a DMEK procedure, actually it helps your cataract surgery because we can see into the eye a lot better. One thing that is important is that we don't want to hurt your DMEK. So with cataract surgery, there is some normal loss of the endothelial cells, those cells that pump the fluid in and out of the cornea. And with DMEK surgery, we really want to protect those endothelial cells as much as possible so that the transplant doesn't reject or fail after the surgery. So it's important for the surgeon to protect the cornea as much as possible during the cataract surgery, but it's definitely still an option to have the cataract surgery after you've had DMEK.
And I think we answered this one. It said, can surgery be done with early macular degeneration? As you said, if it's dry, should be okay. Just be a little more careful if it's wet, correct?
Correct. Yeah.
And here's a question I'm going to send to Dr. Dollywell afterward, because it's a patient of hers and it's kind of a specific question. How much activity is limited after surgery?
So I normally ask my patients to not lift anything too heavy, above 10 pounds, or to bend with their head below their waist for about 1 week. So just 1 week. And then we ask you to wear a protective cover over your eye while sleeping for about 1 week too.
Okay. And I think a lot of concern about retinal detachment. So does cataract increase chance of retinal detachment? I think we've answered that. Will the eye center, okay, so the eye center be purchasing a laser system for removal of cataracts that was tested a while ago? Okay, so answer to that?
I'll take that. So, we are very open to new technology, and we are evaluating our options at this point. I think we are going to ultimately invest in technology that will help our patients, but we're going to have a laser system that will help with corneal dissection, as well as that can be used in cataract surgery, and maybe even in LASIK. So yes, eventually we will have that, and it's going to be housed in our new center, because honestly, we are so excited about our new Vision Institute opening, and we'll have that in the New Vision Institute, in the operating rooms there.
All right, last question. So the last question is there a typical distance near and or far that persons would be able to see after surgery with monofocal lenses?
So that depends on what you would want after the surgery. So if you said, you know, you wanted good driving vision or vision to see the captions on the TV, that's typically, you know, we give you full distance vision. If you want your focal point to be set for using the computer or reading at a arm's length, then that would be more of a intermediate. And then close reading would be near. So that really, we determine that based on what you tell us your needs are for where you want to set that monofocal lens.
Wow. Well, thank you again. This was really a great program. I want to thank everybody who attended. Certainly want to thank again our presenters, Dr. Dhaliwal, Dr. Kamiar, and thank you all. I want to end with one thing. Again, the Eye and Ear Foundation, our focus is on advancing care. And you may have seen this week, we had a really big announcement, something that advanced care significantly for people with retinitis pigmentosa. That was an announcement that came out regarding what some work that Dr. Sahel has done in Paris and now here in Pittsburgh. So this is the goal. We are really trying to push the envelope in terms of advancing care and finding new ways for people that are struggling with these conditions that are very vision threatening and addressing them. So, so thank you for all of those who have supported these efforts. As you see, we're making big strides here in Pittsburgh. We're excited about all that's going on. And we're very, very happy to be working with the wonderful team of people at the UPMC Eye Center and the University of Pittsburgh Department of Ophthalmology who are doing all the great work that you're hearing about today. Thank you, and have a great day.
Thank you. Thank you, everyone. And Lonnie, thank you so much for all of your efforts and your team. You guys are truly amazing. And the Eye and Ear Foundation has made a difference in so many patients' lives because they fund our research and they really help so many different types of programs. I think that the news that you just shared about Dr. Sahel, our chairman, and the groundbreaking research, it was picked up by the New York Times and a lot of different channels. We have to spread the word in Pittsburgh itself on how amazing, these breakthroughs are to help blind people see. So a lot of excitement, and Rohina, you just did an amazing job. Thank you so much for that wonderful presentation. It was fabulous. It's such a, complex topic to distill down, and it was just beautiful. Thank you.
Thank you.
Thank you again. All right, everybody have a wonderful afternoon. Enjoy the sunny day.